distal end. It actually comes like this from here. So if there is a fracture in the middle like this, so this segment will lose its blood supply and undergo avascular necrosis. So in a fracture scaphoid, it is essential that they will open it and they will actually wire the bone up so that both segments of the bone or the fracture ends will get enough blood supply. The pain of fracture scaphoid is felt in the anatomical snuff box, what we discussed yesterday. Is it okay now, Rida? Is it okay? My voice and my... I think I should be using the laser pointer rather than labeling. Okay, thank you. So coming to the bones of the hand, so again here, I will just revise for you. Now I have to identify the medial and lateral. I can see the thumb here. Why do I say it's the thumb? You can see the thumb has only 2 phalanges. It has only phalanx 1 and 2. So this side is my thumb. So again, if I want to see my carpal bones, this is pisiform, triquetral, lunate, scaphoid, trapezium, trapezoid, capitate, hamate. Hamate has a hook here. So these will be my carpal bones. The yellow bones, which are usually present here, they are the metacarpal bones, which are the bones of the palm. I go to my digits or my fingers, I will find phalanges. All the fingers have 3 phalanges except thumb, which is quite short, has only 2 phalanges. So we call it as, the green one is the proximal phalanx, the blue one is the middle phalanx, and the orange one is the distal phalanx. So whenever we talk about attachments, so if I say proximal, it is more towards the body. Distal means it is more away from the body. So now how to number our fingers? So in the anatomical position, the hand being supine, you number the thumb as number 1. Thumb is always number 1. And then the index number 2, middle number 3, ring number 4, and the little finger number 5. So when I say second metacarpal, it belongs to the index finger. When I say the 5th metacarpal, it belongs to the little finger. So that's how you differentiate the fingers by the number. So now I'm going to start dissection one layer by layer. So usually in the hand, we just go by dissection. So when we dissect, we can see they have actually removed the skin, or they have just peeled off the skin. The first thing I see in the skin is that the skin of the palm is thick and hairless. It is a thick skin. You will have abundant of sweat glands, but no sebaceous glands and hair. The reason? Anyone can tell me why the hair does not have any sebaceous glands? Anybody knows that? No? Okay, it's in your general anatomy. Yeah? You can go and look for it. So it has got many sweat glands. And the first thing I see is a small muscle. It's called as palmaris brevis. So if you see here, they have shown the tendon of palmaris longus, which comes from the common flexor origin, that is medial epicondyle, and inserts into the palmar aponeurosis. So the palmaris longus comes from the elbow. The palmaris brevis just takes attachment and from the flexor retinaculum and inserts into the palm. So both of these will help to corrugate the palm, or if you're going to have a tighter grip, you need a tighter palmaris longus and palmaris brevis muscle. So when I dissect the skin, that's the first thing I see. Then we go for the second layer of dissection. We can see the deep fascia or palmar aponeurosis. So here again, I can see the palmaris longus over here. I can see the palmaris brevis here. This white thing here is the carpal tunnel. So when I go forward here, I find a whitish band of tissue. So in this slider, they have not yet fully seen. So this is how the palmar aponeurosis looks. Because they have not fully removed the skin, you cannot see it here. Here they have fully removed the skin, so you can see the palmar aponeurosis. So aponeurosis is a flattened or whitish collagenous tissue, which is if it is rounded, we call it a tendon. If it is flattened, we call it aponeurosis. So this is basically triangular in shape. The apex of the triangle, it is attached to the flexor retinaculum and receives the insertion of the palmaris longus tendon. The base is actually divided into 4 slips. So these slips will go up to the tip of the fingers or the base of the fingers. So now here, So this one, why is it important? Because superficially it is attached to the skin and deep is usually attached to the flexor sheaths. So this also, so when you contract your palmaris brevis muscle or contract your palmaris longa muscle, you actually tense your palmar aponeurosis. You tense it so that the grip is firmer. So people who do tug of war, they should have a very good palmar aponeurosis. So what happens if you have a lesion of palmar aponeurosis? We call it as Dupuytren's contracture. So this is called as localized thickening and contracture. So imagine people who are doing jobs involving vibration. Like for example, they are going to use a vibrating machine to put. They usually drill, especially drilling machines and all. The motion is actually vibration. So, and in people with alcoholic liver disease where there is poor metabolism, same as diabetes mellitus, smoking, repeated trauma to a particular area. So this palmar aponeurosis is nothing but fibrous tissue or collagen. So it will rupture, it will heal back. It will rupture, it will heal back, forming a scar tissue. The problem with scar tissue is that it will not extend and will contract. It lacks its elastic properties. So automatically it will contract. So when it contracts, you can see the attachment goes up to the tip of the fingers. So the moment it starts contracting, it will pull the fingers. It is so strong that it will actually pull the fingers inside into the thumb. So this is actually called as Dupuytren's contracture. It's very commonly you can see in alcoholic people, jobs involving drilling machines, especially repeated trauma. I've seen people with repeated trauma. So the treatment here is they will open it up and they will cut the palmar aponeurosis and release it. So this is called as aponeurosis release. Okay. So continuing further. So I have removed the palmar aponeurosis now. So when I remove the palmar aponeurosis, I can see tendons of the hand or the fingers that can come from the forearm extending up to the tip of my fingers. So number one, I removed the skin. I saw palmaris brevis and longus insertion. Number two, I saw the palmaris. I removed those muscles. I can see palmar aponeurosis. When I remove the aponeurosis only, I can see these tendons. So what are the tendons that come from the forearm and go to the hand? So the tendons is number one, which goes to the thumb, which is the flexor pollicis longus. Number two tendons which come from the forearm to go to the other fingers are flexor digitorum superficialis along with flexor digitorum profundus. Here, the superficialis is seen. The profundus is only seen inside here. You cannot see it. We have to remove the superficialis to see the deep ones. So this is in my palmar aspect. When I see the back of the hand or the dorsal aspect, this will be my flexor extensor retinaculum. I can see the extensor expansion. So this extensor expansion, what is the tendons it contains? It contains extensor digitorum longus. It also has few from the extensor pollicis longus, digiti minimi, which goes to my little finger, and indices, which goes to my index finger. So you see pollicis is special for the thumb, indices is special for the index finger, and digiti minimi for the little finger. So they will extend irrespective of the flexion of the middle two fingers. So these are the tendons I can see when I dissect further. So these tendons, are they alone or they have a covering? Of course, they have to have a covering. Why? Because we are constantly using our fingers. So if you see, this looks like a package of a mummy, how you mummify a person. So actually it's like bandage like this. So this is nothing but fibrous tissue which actually covers the tendon. So if you see here, they have cut open the fibrous tissue. This actually covers the tendon. This is closed distally. Here, this part is closed. It is open proximally. You can see it is open here. So actually the tendons will come from the forearm, go under the palmar aponeurosis, travel here, enter this fibrous tunnel and run through the tunnel. Why is it covered? Because constantly we are using our fingers. If the tendon is actually lying on the bone, there is a high chance of the tendon going in for rupture because of the constant movement. So that's the reason we have this fibrous flexor sheaths. Okay, so I'm just thinking, do we just stop with the fibrous flexor sheaths or they have something else? So now I'm removing the fibrous flexor sheets. I can see the tendons covered with a synovial membrane. Why do you have a synovial membrane? Anybody?
Reduce friction.
Yeah, there's reduced friction. Thank you. So this synovial membrane, if you see, it secretes a synovial fluid so that it lubricates the tendons when we constantly move our fingers. So when we are doing things with the hand, we actually don't know that whether we have a fibrous sheath or a synovial sheath. We do have, and it helps in our lubrication. So if you would see here, this synovial sheath is continuous from the little finger and the flexor pollicis longus tendon for the thumb. So this synovial sheath on the radial side is called as radial bursa, and on the ulnar side it is called as ulnar bursa. But for the other three fingers, the synovial sheath stops and then it starts back again at the beginning of the fingers. Why is it important? This is because if a person, very commonly we get a thorn prick injury. I took a rose and I got prick here. I did something, and also for doctors, needle stick injury. For people, tailors, the needle injury. Very commonly they get those injuries. So those injuries, if you inflame the synovial sheath, it can spread all the way up to the forearm. So you have to be, when a patient comes with a prick injury, the finger matters. So if you know it's a deep prick involving the thumb or the little finger, you would of course take an extra care, because you know if you inflame your synovial sheath, it can go up to the forearm. Okay, so this is what we call, this is the synovial sheath. So first I removed the skin. I saw palmaris brevis, I saw palmar aponeurosis. I removed it, I saw tendons. But the tendons are not alone, they are surrounded by fibrous sheath. So here the fibrous sheath is only in the fingers, it is not in the palm, because you still have good muscles over here, so that they actually they are forming a bed, a nice bed-like structure for the tendons. But in the fingers, it is left only the tendons. So you need something to cover it up. That's why you have fibrous flexor sheaths. You cut it open again, you will find synovial sheaths which lubricate the tendons. If you have a synovial membrane, you will have synovitis. So synovitis is inflammation of a membrane. So here we call it as infection of a synovial or inflammation of a synovial sheath because of a bacterial inflammation. So if you have that, you will have the cardinal signs of inflammation: rubor, calor, dolor, all of it you will have. You will have pain, you have color, you have secretions, loss of function. So all the inflammatory secretions will be pouring into the synovial sheath, so it will increase in size. So the finger is very painful, semi-flexed and swollen. You cannot extend your fingers. If you attempt to extend your fingers, it will cause very severe pain. So the sheath, the fibrous sheath, as well as the synovial sheath they can withstand only some pressure. If the fluid keeps on increasing, automatically it will go for rupture. So if it goes in for rupture, it will actually, the pus can enter to all facial spaces of the palm. So that's why it is very, very important to look at thorn prick injuries, needle stick injuries, as well as needle injuries for tailors. So we might think it's a very trivial infection, but if you don't treat it, I remember I watched a series called as Good Doctor. There is a pianist or violinist. She comes with a tenosynovitis, and then they undermine the infection, so they end up having amputation. So she loses her career. The Good Doctor series is quite good. You can watch it. So this is the clinical correlates of the synovial sheaths. So now we come to the insertion of the tendon. So we say we have tendon of flexor pollicis longus, flexor digitorum, superficialis, and profundus coming from the forearm going to the hand. So how do they insert? So number one, I will do the flexor pollicis longus. So the flexor pollicis longus, you can see I'm just tracing the muscle, then becomes a tendon. It goes and attached to the distal phalanx. It flexes my thumb. That is quite straightforward. But when I go to the other four fingers, I have two tendons. One is superficialis, which is shown in yellow color. This is actually a superficial tendon, and a deep one or a profundus, which is green color. So both have to insert into the phalanges. So superficialis, it will divide into two. Can you see? It divides into one branch here, another one here, and insert into the middle phalanx. So here, this is the metacarpal, this is the proximal phalanx, this is the middle phalanx, and this will be the distal phalanx. So it goes and inserts into the middle phalanx. Why does it split into two? Because it allows the tendon of flexor digitorum profundus to pass through. So this is the reason you have this one is your flexor digitorum superficialis dividing into two and allowing the digitorum profundus to pass through. So tomorrow when we do the lab guide together, I will show you pictures which we take from our own specimens in campus. Your lab guide has those pictures. So there I can show you how the split is happening and then how it allows the profundus to pass through. So that profundus will go up to the distal phalanx. So this is the attachment of the long flexor tendons. Coming on to the extensor side, how does the long extensor tendon insert? So yesterday someone was asking me through WhatsApp, like, how does the extensor expansion even insert, doctor? Okay, this is the answer for the person. Okay, so the extensor tendons, you know, they form a very nice expansion in the dorsum of the hand or the posterior aspect of the hand. When they go towards the fingers, this expansion will divide into three splits. One center, two lateral. The center will go and insert into the middle phalanx. The lateral will go and insert into the distal phalanx. So whereas flexor, if you see, you have two tendons, one for the middle, one for the distal. But extensors, you just have an expansion. The same thing has to cater for itself. It has to cater for itself. So it will divide into three. The center one will go and insert into the middle phalanx, and the lateral ones will go and insert into the distal phalanx. So this is the insertion of your extensor expansion. Then you can ask, what about extensor pollicis longus and brevis, doctor? It just forms one tendon and goes and inserts. It doesn't, because you have extensor pollicis longus and brevis. The brevis will go up to the proximal phalanx, and then the longus will go up to the distal phalanx. So thumb is special case. It has two muscles, so it has the liberty, one to go and insert into the proximal and one to be in the distal phalanx. Whereas the other four fingers, it will divide like this. Okay. So what will be the clinical correlates for this? Number one is mallet finger. So when somebody is throwing a ball at you, especially volleyball or basketball, you tend to cup the ball and hold it. What if it lands on the tip of your finger? The moment it lands on the tip of the finger, you can see it causes extreme flexion. When it causes extreme flexion, you will rupture the lateral tendons of the extensor expansion. So when you rupture the lateral tendons of the extensor expansion, the extension of the distal interphalangeal joint becomes impossible. So the patient comes with a hyperextended finger, but the distal end is like a beak. So this finger is called as mallet finger. Mallet finger can be congenital. I have seen people with mallet finger since birth. So it is not because of they have injured their tendons. It's because they make itself like that. Maybe they have tighter tendons over there. Actually, if it is too tight, if it affects your daily job, they will go for a release. If not, they can survive. It's not a big it's not a big disease if it is congenital. But if it is injured like this, we would want to put it back again because the person has been used to having normal fingers. Okay, so this is one injury. So if you rupture the lateral slips of the extensor tendon, which is ruptured over here, because you miscaught a ball or something comes and hits at the tip of your finger, the force is too high, it will go for a rupture. So you cannot extend your distal interphalangeal joint, so your finger looks like a beak. So this is called as mallet finger. The other problem is Boutonniere deformity. So if you see this figure below, you have inflammation of this joint. This is called as, usually it is seen in rheumatoid arthritis in women, especially women. Rheumatoid arthritis is very common. Dr. Bushra will talk about the pathology of rheumatoid arthritis, but I will just give you a brief. It's an autoimmune disease. You have antibodies against your own joint synovial membrane. So there was constantly inflammation going on in the small joints. It begins with the small joints of your fingers. So when there is antigen antibody reaction, there is a lot of pannus or synovial membrane. The spoils of antigen antibody reaction which gets accumulated around the joint. So as a result of it, if you see in this extensor expansion, there is no cover. Actually, you will have a synovial, you will have a fibrous, but muscular, there is nothing here. It is not that fleshy. So there is a high chance of the tendon being rubbed against the joint. So when it's rubbed against the joint, it ruptures. So when it ruptures, you can see the central tendon is the one which ruptures, not the lateral. The lateral goes to the distal. So when the central ruptures, the finger is like a buttonhole deformity. So you cannot extend your proximal interphalangeal joint, but distal you can extend. So the hand looks like a knee downer. So this proximal interphalangeal joint is flexed, but the distal is normal. You can extend it. So this is just the opposite of your mallet finger. So these two can occur because of rupture of the extensor tendons. So again, I give a recap. I open the palm. I find out the skin, palmaris brevis, palmaris longus, palmar aponeurosis. I have removed the palmar aponeurosis. I find the tendons covered with fibrous sheaths. I remove the fibrous sheath. I find synovial membrane. I remember it can cause tenosynovitis. Then when I remove the synovial membrane, I can see the insertion of flexor tendons. I put my hand back again. I see in the dorsal aspect, the insertion of extensor tendons. And I remember it can either cause mallet finger if the lateral slips are ruptured, and it can cause boutonniere deformity if the central slips are ruptured. Akmal, can you just send in the attendance link now so that people can mark the attendance?
All right, Doctor.
Okay. So I just give you 2 minutes for that. You can just mark your attendance.
Doctor, for the central slips, which fingers are they exactly?
You mean to say central slips, the 4 fingers?
So in this cases of injury, it affects all the 4 fingers.
Which finger is actually getting ruptured? You can see in this picture. The index finger, right? No, middle finger. This picture shows the middle finger.
Right, Doctor.
Yeah, this shows the middle finger. So it depends upon which finger. Usually the common is index and middle finger. Why? Because they are quite long. So it can easily get injured if something comes and attacks the tip. Okay, let me continue. So I hope you have marked your attendance. Let me drink some water and I will continue. Okay, so coming to the muscles. So now I have removed all my, so you see, they have cut all the tendons over here in the fingers. So if you see, this is the tendon of flexor digitorum superficialis. I'm showing the ring finger, the tendon of flexor digitorum superficialis. You can see it splits into 2 to allow the tendon of flexor digitorum profundus attached to the distal phalanx. So this is the tendon. So now I can see quite a few muscles in my palm. These quite a few muscles, this is the thenar eminence. I have written thenar. Here is your hypothenar eminence. So you see, oh my God, there are quite a few muscles here. Okay, so how to categorize these muscles? Huh? So we categorize these muscles as radial side acting on the thumb, ulnar side acting on the little finger, and intrinsic muscles. So what I see here is only radial side or thenar and hypothenar muscles. I cannot see the intrinsic muscles unless and until I remove even these muscles. That is the deepest of all. So if you look at this table, it looks crazy. So don't look at the table. We look at the figure. So what do I want you to remember here? As I told you again, the thumb has a lot of actions. So we already saw yesterday it has got an abductor pollicis longus, it has got extensor pollicis longus, flexor pollicis longus, extensor pollicis brevis. So it has got longest muscles. So the short version of it is here. Abductor pollicis brevis. So the meaning is it abducts my thumb, but it is a short muscle. So it just comes from the carpal bones and flexor retinaculum and goes to the middle phalanx. Just nearby that, I have flexor pollicis brevis. So it comes from the flexor retinaculum, goes to the middle phalanx. It flexes my thumb. So this is very similar to the action of the forearm muscles. Plus, this is the important one we have to remember. I have two muscles which are special to the thumb, which I call it as opponens pollicis and adductor pollicis. If you put your hand there, your thumb always stands outside. The thumb is not in line with other fingers. So I have to bring it in line with the other fingers. For that, I use opponens pollicis and adductor pollicis. So opponens pollicis, if you'd see, it will just attach to the flexor retinaculum to the metacarpals. So when I use my opponens pollicis, if you had watched the video on thumb movements, if I count the fingers, if I touch the tips or pads of the fingers, the other fingers, that is my opponens. I count like 1, 2, 3 by just touching the tip. That is my opponens pollicis. So what is the function of adductor pollicis? Adductor pollicis, it pulls the thumb towards my other finger. So it makes it stand very close. So that is my function of adduction. So how do I classify this? So abductor, flexor, opponens, all supplied by my median nerve. When I go to my adductor pollicis, this one, it adducts or bring it closer towards the ulnar side. So that's the only muscle that is supplied by the ulnar nerve. So when I look at the intrinsic muscles or the muscles, small muscles of my thenar eminence, I know I have an abductor, I have a flexor, opponens, and adductor, but all three are supplied by median. Only the adductor is supplied by the ulnar. Why? Because it pulls the thumb towards the ulnar side. So that's how I differentiate. Again, I don't want to know about the attachments here, but nerve supply is important. Okay. So coming to the little finger. Little finger, the same story here. It has got three muscles, but it does not have adductor. It doesn't need any adduction. It is already adducted towards the midline. So I have a abductor digiti minimi, I have a flexor digiti minimi, and I have an opponens, which is the deepest of all the muscles. So they also take origin from the flexor retinaculum and go to my little finger. So this also helps in abduction, flexion, and opponens. So all three are supplied by the ulnar nerve. So again, in this figure, you can see this one, like bandaged one, is your fibrous flexor sheath. I have removed the fibrous flexor sheath. I can see the superficialis split into two and the profundus passing through. So this is again a picture, it shows that. So for your small intrinsic muscles of the hand, on the radial side, you have to know, yes, I have an abductor, I have a flexor, I have opponent and a adductor, of which adductor is the only one supplied by my ulna. Coming to my ulna, I don't need an adductor because it's already adducted or towards my midline. So I just have an abductor, flexor, and opponents. So for that, I will just be supplied by the ulnar nerve. That's all. So that's what you're supposed to know. So this is the intrinsic muscles of the hand. So intrinsic muscles of the hand must know. It's quite important because a lot of palsies can occur involving the intrinsic muscle. Again, the attachments are not very important. We just go by the figures and the nerve supply. Okay, so I have given it in tables just for your understanding. If you just read it once, you will understand where it runs through. That's the reason I have given it. So we have three intrinsic muscles. So these three intrinsic muscles, so if I split the thenar and hypothenar, remove the center, all the vessels, then only I can see the lumbricals. Lumbricals means worms. The muscle is actually wriggly. It runs like a worm. So where does it take its origin from? This is the flexor digitorum profundus tendon. It takes origin from the lateral aspect of the tendon and goes to the extensor expansion. So actually it takes origin from the palmar aspect but inserts into the dorsal aspect. So what is the speciality of lumbricals? This will cause a flexion of the metacarpophalangeal joint and extension of the interphalangeal joint. So this is very important for your pincer action, or if you want to hold a pen or you want to hold a thing, this is very, very important for you. So here, if you would notice, this muscle arises from the palmar aspect and goes to the dorsal aspect. So you have 4 lumbricals. The lumbricals on the lateral aspect, the 2 lumbricals towards the thumb, they are supplied by median nerve. The lumbricals towards the little finger, they are supplied by the ulnar nerve. So actually they split their nerve supply. So what happens if there is a median nerve injury? So if Dr. Atika would have taught you, she would have taught about hand of benediction. So next week you have a class again on nerve lesions of upper limb. So I will teach you again how the lumbricals will be involved in hand of benediction. So for now, you just remember how it is attached. How it is attached, meaning that it just runs from the palmar to the dorsal aspect, and it helps in flexion of metacarpophalangeal joint and extension of interphalangeal joints. I remove all the muscles, I remove all the lumbricals, I remove all the tendon, I see only the bones. That's where I will find my interossei muscle, interossei, in between bones. That's the deepest of all. So if you see, I have 2 interossei, palmar and dorsal. If I see from the palmar side, I can see palmar interossei. If I see behind, I can see dorsal interossei. So the mnemonic I remember for this is pad and dab. Palmar interossei, adduct. That means brings all the fingers towards my midline. Dorsal interossei, abduct. That means it moves away from the midline. So if I keep my palm in the supine position, I want to bring all my all my fingers towards the midline. That means I should bring it towards my middle finger. So if you see in the palmar interossei, there is no palmar interossei for the middle finger because it is the midline area. The palmar interossei is there for the thumb, it is there for the index finger, it is there for the ring finger and little finger. So when I pull it, they will bring themselves towards the middle finger. So that's why the middle finger does not have a palmar interossei. When I go to the dorsal interossei, it is dab. Dorsal interossei, abduct, DAB. So here I have to move away from my middle finger. I have to go towards the thumb. I have to go towards the little finger. So only the index finger, middle finger, and the ring finger have attachment for dorsal interossei. The thumb and the little finger, they are free of dorsal interossei distal attachments. So here it is a bipinnate muscle. So if I pull the first dorsal interossei, I will pull the index finger towards my thumb. If I pull the second one, you see the middle finger has got 2 dorsal interossei. So if I pull both, you can spread your fingers as much as you can. So if I want to bring my fingers together, I use my palmar interossei. If I want to spread out my fingers, I use my dorsal interossei. Both are supplied by the ulnar nerve. So when you see the intrinsic muscles of the hand, 3 muscles on the thumb side are supplied by the radial. 1 on the radial is supplied by the ulnar. 3 muscles of the little finger are supplied by ulnar. The lumbricals split themselves, 2 plus 2. Ulnar and median, not radial, sorry, ulnar and median. And the interossei are all supplied by your ulnar. So that's why yesterday I was mentioning, in the forearm, the median is the dominant nerve. In the hand, the ulnar is the dominant nerve. So actually they take places. That's what I told yesterday. So coming to the next part of the lecture, we have finished the muscles, the facial spaces. So these tendons of the lumbricals as well as the thenar muscles, they are held in spaces. They are covered in a space we call as thenar space or mid-palmar space. So this patient, he comes with an injury. If you see, he had a thorn prick or somewhere here, he has inflamed sinuses. This is inflamed so much that it enters into the palm. So it usually goes into either the thenar space or the mid-palmar space. So that's why when we have infections, it can easily spread into the spaces around the tendons or around the lumbrical. So it's very important to treat those infections well. You just cannot look past through it. Okay, so the last part of the lecture will be the vascular supply and the nerve supply of this hand. As simple as it is. Again, I repeat from the beginning. From the arch of aorta, you will have the subclavian. On the left side, on the right side, brachiocephalic, dividing into subclavian and carotid. Below the clavicle, I call it subclavian. I move towards the axilla, I call it axillary. I move towards the arm, I call it brachial. When it goes beyond the cubital fossa, it will divide into radial and ulnar. So now I have two arteries which supply. In the forearm, radial is small, ulnar is big. So ulnar supplies an interosseous or an anterior interosseous branch, and also it has another posterior interosseous branch which will supply your posterior part of the forearm. So once it is finished supplying, in the hand I can see the radial artery here and the ulnar artery here. So this radial artery, it is superficial throughout its extent, crosses the anatomical snuff box, and first it gives rise to a deep branch. Then it will then divide into a superficial branch. So what happens to the deep branch? So this deep branch, the figure on the right side, it will form a deep palmar arch. Forms a deep. This palmar arch is met by the ulnar artery or the deep branch, so that completes the arch. The superficial also forms a superficial palmar. Both will divide into superficial and deep. Both superficial will form a superficial palmar arch. Both deep will form a deep palmar arch. Once they form arches, they will then give rise to branches that go to the fingers. We call them as digital arteries. So this shows that how well the blood supply is here. So if you want to test the blood supply or the vascular supply of the hand, first you make a fist and then you hold your wrist very tightly. When you open your